Okay, this is it. This is the last hour. Can everybody hear me and see me? Yes? Okay. I was just having a conversation with the techs. If you've ever, how many of you out there ever have a moment where you just want to scream? Have you ever had days like that where you just want to go? It's kind of like catharsis, right? Doesn't it make you feel good? Yeah. I've been wanting to feel like that all day. Yeah, it's increasing frequently, right? Okay, I can't do it at work because I know what will happen to me. They'll probably put me in some rubber room or something. Okay, did everybody get this already? So all of you copied this here? You all understand it? Alrighty, let's go. Are SSRIs and TCAs all safe in pregnancy? When you talk about pregnancy, what you have to focus on is benefits versus risks. So as long as the benefits outweigh the risk, then you can use medications. But if the benefits do not outweigh the risk, then you cannot use medications, okay? Okay, so let's go. You asked for some questions, and I've given you some questions. Okay, let's go to question this one. Question this one. Let's give it a number. Question 1. 70-year-old man presents with a 2-month history of depression. And I didn't bother giving you the signs and symptoms of depression because, I mean, he has trouble eating and has lost more than 45 pounds. His daughters are concerned and ask you for help. Which of the following would you recommend? Do you want the pod? Do you want the answer pod? Yes or no? Okay, let's get the answer pod out there. Let's get the cephalopod. There we go. I'll give you 30 seconds. I don't have any way to count 30 seconds, but I'm going to pretend. Oh, 1 Mississippi, 2 Mississippi. Okay, let's call it quits. Let's end the poll. The poll is closed for voting. Okay. So a lot of you put A, because what did I say about the rules? SRI, right? Did I not say that? Did I say that to all of you? Yes. But didn't I give you exceptions? If there was a pill, if there's a choice that you can kill 2 birds with 1 stone, use it. So we have depression, we have insomnia, and we have weight loss. So tell me, well, insomnia is not there. Never mind, my bad. So we've got depression and we've got weight loss. So is there a drug that will do both? Hey, what happened to the poll? It disappeared. Did the poll go away? Huh. Oh well. So the answer is D. If D is not there, then we pick the depression and we would pick A. Are we okay with number 1? Number 2. A 21-year-old male having trouble with his marriage over his sex life. His wife complained that he never waits for her and just has his orgasm and leaves her waiting. How rude. Because of his marriage problems, he has become depressed. He expresses feelings of hopelessness and helplessness. Which of the following would you recommend? And you're off. This one's easy. Okay, I'm going to end the poll. Wow. Here's what happened. We are using the poll, right? Okay, here's what happened. You read the word sex, and you immediately went to bupropion. What sexual dysfunction does he have? What does he probably have? Premature ejaculation. Remember, that you're done, and your partner is like, now what? What's up? What's that? Where am I? So because of that, what kind of drug will do 2 things? We need to treat the depression, and we need to slow it down. What's the drug that will do that? The SSRI. Had the question been, he is fearful of sexual side effects, then what would be the better answer? Then it would be bupropion. Behavioral therapy really is not for depression. Trazodone's not in there. Trazodone is for erectile dysfunction. That's not what he has. Okay? No, it doesn't say that it's because of it. It doesn't matter what causes it. The matter is he's depressed. So you got to treat both. It's not squeeze and go. It's stop and go. I mean, you could squeeze and go, but that's not the goal of the treatment. So does everyone understand number 2? Okay. I understand. It doesn't matter. It's like, what came first, the chicken or the egg? The issue is he's depressed, so I've got to treat the depression as well. So we got to treat both the chicken and the egg, not one or the other. Oh, that is funny. Yep. I guess he did come first. Brum, bum. Okay. Sertraline because it's an SSRI. So what's the answer for 2? Number C. B is, had it said he is worried about sexual side effects, then the answer would have been B. Everyone agree? Okay. Another question. A 25-year-old bipolar patient is 3 months pregnant and has become depressed. She worries about her baby and what could happen given the horrible world we live in. She is not eating, drinking, worries incessantly, has no pleasure in activities, and is losing weight. Her doctors are concerned. Which of the following would be the safest treatment for her? Let's get the poll out here again. My dog has lost his mind, I'm telling you. Peanut, stop it. Okay. Let's stop the poll. What does she have? Depression. And she's pregnant, right? So what would be the safest thing if you're depressed and pregnant? ECT. Now, let's talk about medications. Paroxetine is the only one that is category D. D is not good. So, whatchamacallit, paroxetine. So if you're saying, okay, I could give her an antidepressant, and I would say to you, yeah, you can. But you're not going to give her paroxetine. Why do we not use paroxetine? Because it's category D. It's the one where there is definite proof that use of the medication causes fetal malformations. So that's why I chose paroxetine to put it in. You don't pick that one. Now, I told you that lorazepam is safe, right? But lorazepam is an antipsychotic. You use it for bipolar depression, and you use it for schizophrenia. You don't use it for pure and simple depression. So that is why lorazepam is not the correct answer. So what would it be here? C, ECT. Does everyone understand this? Where does it say that she's bipolar? Oh, true. My bad. Sorry. But what is the safest treatment for her? Sorry. What would be the safest treatment for her? When you compare meds to ECT, then still ECT. Okay? Now, had it said not, but something like most likely, then what would be the answer? Exactly. Then you pick B. So be very careful between best or safest to most likely or most common, because they're very different here. Does everyone understand those subtle differences? Could lithium be given? Yes. All right. Oh, okay, let's repeat. Let me get this poll out of here. Let me clean this up a little bit. Hold on. Oh, that wasn't helpful. Here, let's go over here and start again. So you're bipolar, and you're pregnant, and you're depressed, right? The question was safest. Whenever the word safest is there, ECT is the answer. When they're asking you most likely or most common, then meds become the answer. Because you are pregnant and you're bipolar depressed, then lorazepam would be the best. Why? Because it's category B. So it does not affect the baby. Yes, ECT is the best. Sorry. Yes. Remember, lorazepam is not for depression. Lorazepam is for bipolar depression. Correct. No, lorazepam is for the depressed, bipolar depression. It's an antipsychotic that is FDA approved for bipolar depression. Is lorazepam preferred over ECT? If the question says safest, no. But is it routinely preferred over ECT? Yeah. Most definitely. Can we use lamotrigine? No, because lurasidone is safer. Oh, you mean if it were there? Then yeah, you could use it. So is this one okay? All right, let's go to the chapter on suicide. Let's get rid of this. And let's talk about suicide. Have you done Epi Public Health yet? Okay, you will. Who covers it for you? Is it Dr. Facelis or Dr. Kudroth? Okay. He will go over a lot of stuff. He's going to go over the ethics. He's going to go over informed consent. He's going to go over all that junk. Oh, it's not junk. I'm sorry. You know what I mean. So all I'm going to do here is go over suicide. If I can get my slides up here. Okay. Nope, that's not it. Suicide should be chapter 18 or 19. I was told that they were up there and ready to go. 18 or 19, because I think this chapter, and there might be different headings. Nope. It's chapter 19. Whoa, what happened? Ah, there it is. Sorry. All right. Well, that's not a happy picture. That's not how I want to end my night. So when we talk about suicide, that's pretty morbid. When we talk about suicide, let me go to the whiteboard for a second. We want to assess suicide 3 ways. We want to know if you're thinking about it. That's called ideation. We also want to assess intent, meaning I'm serious about it. And I'm going to assess plan, which of course means I plan it. So when we look at these 3 things, 1, 2, and 3, you should assess all of them. What happens with questions is the following. So you get a question. They tell you about a patient who's depressed and has suicidal ideas. And then they're going to say, what's the next step? And then what they want you to put down as choices are, let me go for the text, give me a second. Text, where are you? Do you A, admit, B, refer to psych, C, begin antidepressants, or D, assess further? What do you think? Oh wow, we're split. We're pretty much split. And the correct answer is assess further. This is never wrong. I mean, sorry, this is always wrong, so don't you dare pick that on step 2 because you're going to get it wrong. This is wrong. So assess further is the better answer. Why? Because you know what? A lot of people think about it, but they're not serious about it. So I could say to you, how many of you have said to yourself, ugh, you know, if I were dead, I wouldn't have to take this test. If I were dead, I wouldn't have to go to work tomorrow. We say it because that's what we do, but we're not serious about it. So just thinking about it means nothing. It's a layer. So the best answer is we assess further. Does that make sense to everybody? We want to know if they're serious. We want to know they have a plan. Let's change the question a little bit. This is not there. So you got the depressed patient that says, I've been thinking about suicide. And then the question says, what's your next step? Now, there's no way for us to figure out what else is going on. So now we think of safety, right? So when you're dealing with patients that are suicidal, you've got two possible mistakes. You admit someone that's not suicidal, or you send someone home that's suicidal. So if that's the question, then what would be the next best answer? Then admit becomes the better answer. Does that make sense to everybody? So we want to know if they're serious and if they have a plan. Also, looking at the plan will help us determine the intent, right? So is my plan to do it when I'm alone, use a method that's very lethal? Or is my plan to do it when I'm with my friends and use a method that's non-lethal? Which one, even though they both have plans, which one has the real intent, A or B? So A is much more serious. Now, what if the plan sucks, but you thought it was a great plan? You thought you were going to be successful. Do you have intent? Yes or no? So if I thought 4 Tylenol would kill me, and I take 4 Tylenol, I write a suicide note, I do it in a cabin that's far away where no one can find me, right? I take the GPS off my phone so you can't track me. This plan, listen, you're not going to die from this, but as long as I think I'm going to die, that's a lethal plan for me. Does everyone understand that? Okay, good. So let's go to the notes. Let's review suicide stuff. So when you see people who are suicidal, you need to understand that most of them have attempted again. So most of them will have a recent attempt. Usually you attempt within 3 months of the first one. They talk about it. This is a suicide myth. They're serious. They're not going to do it. They are going to do it. I'll tell you a story. There was a patient at the VA who, I heard this story from someone else, who had told his family, on such and such a day, I am going to kill myself. When that day came, and the family said, nah, you're just blah, blah, blah. When that day came, they couldn't find him. Now everybody's worried. They call the police. They go to his house. He's dead. He told you about it. So people who are suicidal do tell people. When you ask them, they're honest. They're going to tell you. They demonstrate suicide behavior. What in the world is suicide behavior? Well, you buy weapons. You buy a gun. You write a will. You give away your stuff. You go to the doctor. Those are things that are suicidal behavior. What do we find? So what we have in suicide is that we're going to look at risk factors. As a psychiatrist, I don't have... Did all of you see Harry Potter? Yes? Okay. Do you remember the sorting hat? You put the hat on and, oh, you go to Gryffindor and you go to, I forgot the name, Rumpelstiltskin or wherever it is that you go. We as psychiatrists do not have a suicide hat that tells us you're going to commit suicide and this person is not. So all we can do is look at the risk factors. The more you have, the more likely that you will admit that person. And if you ever feel, that's where I think psychiatry, you have to listen to your inner voice. If you ever feel uncomfortable, what's the safest thing you should do? You admit them, right? You admit them. How is going to the doctor suicidal? It's not that they go to the doctor. What happens is that they found that most people who commit suicide have visited a doctor. And why is that? Because they're not feeling well. Many of them are depressed. The doctor doesn't recognize the depression, doesn't diagnose it, doesn't give them treatment, and then they go out and kill themselves. That's what it is. So we know that whites kill themselves more than blacks. We know that men kill themselves more than women. We know that women attempt more than men. We know that when both commit suicide, we know that firearms are the #1 method. So even though men and women are using firearms, why are men and women not dying in the same rate? Well, because men will probably put the gun here, women will probably put the gun here. So the method is a little bit different. Even though the gun is the same, where they put it is going to be a little bit different. So we know that previous attempt is high risk, men more than women. White, elderly male is the highest risk. So if they ever give you a 50-year-old, a 60-year-old, and a 70-year-old, pick the oldest one in the bunch. Those that are alone, isolated, are at increased risk. So what does that mean? Separated, divorced, and widowed have higher rates than single, have higher rates than marriage. The rate starts going up, like 50 and up. That's when your rates increase. Okay. High SES more than low SES. Unemployed more than employed. Any kind of illness, if you're hopeless, any mental illness increases your... Remember, SES has nothing to do with money. SES is occupation and education. Okay? So when we're dealing with patients that are suicidal, ask them, talk to family and friends, take all threats seriously, and always admit individuals, okay? So look at the risk factors. The more risk factors you have, the more likely you admit. There's no magic number of risk factors. If you don't feel comfortable, admit the patient. Okay? What is the question? I see some question marks out there. How high SES more than low SES? More to lose. Do you remember in the, well, none of us personally remember, but do you remember in the last several years when the stock market crashed? Do you know how many CEOs jumped from their office buildings? That's why. And it's not money. We're talking about occupation and education. Which one has the worst prognoses? Ask that on a step 2. Okay? So any questions on suicide? This we're not going to go over because it's not in your notes. Okay, let's go over something. Let's talk about involuntary commitment that you should speak with. You should do this with Dr. Kudroth, but let's do it here too, just in case he doesn't cover it. When we admit someone, so how do I admit someone into the hospital if they don't want to be admitted, right? For you to be admitted involuntarily, what has to happen? What are questions going to be on suicide? They're going to give you case presentations, and they want to know, do you admit or do you not admit? Okay. They want to know who's the highest risk, who's lower risk, things like that. But as far as prognoses and predictor. What they do know is that the best predictor is hopelessness. But then you look at other books and it gives you other things. So because these are things that no one has said with 100% accuracy, this is it, it'll never be on the exam. Now, on your exam, every state has different laws, different admission criteria. So they're not going to ask the name of what, like I'm in Florida, we have what's called the Baker Act. When I lived in New York, we had something called 939. California has different ones. Everyone has different ones. So you don't need to know any of that stuff. This is what you need to know. For you to be admitted involuntarily, what has to happen? Well, you need to be mentally ill. Does everyone agree? How many people are mentally ill and walking around the streets of your town? You think a lot or not a lot? A lot. I don't know about everyone, but a lot. Is that enough to be admitted into the hospital? No. You also have to be dangerous. Dangerous how? Dangerous to self or dangerous to others. When both of these are met, then I can admit you against your will. Okay, does that make sense? Mental illness alone is not enough to admit you against your will. You also have to be dangerous. It doesn't have to be suicide. If you're bipolar and you're doing things that are so crazy that you potentially are in danger of hurting yourself, it would be the same criteria. It doesn't have to be in the context of suicide. It's the context of harm. Harm to yourself or others. Okay? So any questions on that? Okay, then let's go to the last chapter. If I could just get the last chapter up and we'll be done. Harm, anything. The last chapter should be on therapies. We're almost there. There we go. Let's get this up there. Excellent. Okay, if they could just zoom it. There we go. Okay, now it gives me great pleasure, incredible pleasure, to tell you that this is low. It's as low as you can go. Okay? It's like a limbo pole. That's how low it goes. So let's just review it quickly. You know, I'm a psychiatrist. And even, what is the yield of the suicide chapter? High. And as a psychiatrist, even in my psych boards, I don't get stuff like this asked. So what kind of questions could they ask you on this? Well, if you want to do this simple, let's do it simple. They're not going to ask you anything on psychoanalysis. Why? Because first of all, we don't prescribe it. Insurance companies don't pay it, so it's not going to happen. Whenever you see the word inside-oriented, that's what they call individual therapy. So individual therapy is very common. You go to individual therapy when you have problems. So if I've been married 5 times and each time I get married, my husband is an alcoholic, then you know what? I got the problem. So individual therapy is going to help me. Why on earth am I picking these people? So whenever they talk about therapy, that's what they're talking about. Supportive therapy is for people who are either very sick or people that are going to get better. So what do you pick as the answer for supportive therapy? people who have grief, right? Or people who have adjustment disorders. That's what will probably appear on the exam. Cancer, exactly. Anything dealing with death and dying, you can do that. Excellent. Good example. Behavioral therapy is to unlearn. So phobias, insomnia, I mean, we talked about it. If I can't sleep in bed because I read, then I use behavioral therapy. If I'm afraid of dogs and I'm a mail carrier, then I need behavioral therapy. So in behavioral therapy, we're trying to unlearn the bad things that we learned. Group is just like individual, except the N is greater than 1. That's it. And a big difference is that it's cheaper. Because if you go to individual therapy, you pay the therapist the full amount. If you go to group therapy, and there's 10 of you, then you share the cost. Okay, this is what tends to come out. This is what I've been told. They have asked 2 things. They have asked, let me go to the text. Give me 1 second. What is cognitive? Oops. Behavioral therapy. And what is dialectic behavioral therapy? They're not going to ask you how to do it. All you need to know is what it's for. Cognitive behavioral therapy is used for depression. It's used for anxiety. It's used for a lot of things. But dialectic behavioral therapy is used for borderlines. So the people who have the borderline personality disorder get dialectic behavioral therapy. People who have depression get cognitive behavioral therapy. This has been a question I've been told. And other than this, don't waste your time on therapy questions. Dialectic behavioral is a therapy created by, I think this woman called Martha, I think it's Linderman or Lanahan, something like that. And she created a special therapy for people who are borderline, who cut themselves and burn themselves and have problems with rejection and abandonment. So that's what this therapy is basically for. Okay? No, you hear whispering. You're not having hallucinations. Background. All right. This is my email. So if you have any questions, email me, and I will be happy to go over anything with you. I'll be happy to go over them with you only Monday through Friday. Remember, this is my work email. So if you send something on Saturday, I won't get it. I'm not one of those crazy people that gets access from home and works. Oh, no. I do enough when I'm there. All right, so good luck. Take care. What about compulsion of scratching? You know, there's a new disorder that they call excoriation or skin picking, and I included it in your little thing. If it's anything OCD-like, you always use SSRIs. How does olanzapine affect the sleep cycle? Remember, it's a dopamine antagonist, so you sleep more. What field within psychiatry is booming these days? Oh, wow. Drugs, forensic, that's where. And child, but you gotta want to deal with those parents. God bless you. I believe you got the notes. I know I got they put it up somewhere. I will ask Mark or Christina. I did send it to them, and I've seen it here in the lobby somewhere. You got it? Okay, so if the text can put them back up so that people can upload it. All right, good night, everybody. Good luck, and any questions, just give me a holler. Take care.